Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Hadidi, who has been on our program before, and we're glad to have him back this time to discuss a topic that he actually uh, uh, was at ASCO a discussant and educational session leader for. And this is the advent of increasing use of four-drug regimens for multiple myeloma. He's at the University of Arkansas, one of the leading myeloma centers in the country. So, welcome, Samir.
Thank you so much for having me.
So, Samir, so your topic at the ASCO meeting was what is the current state of induction with four drug regimens? And can you lay the background for your talk, and then we can dive into how you see the four drug regimens today?
Yes, certainly. In my multiple myeloma, we were lucky to see developments over the years, where a concept of addition of extra drugs on top of active drugs were entertained. So we started, checking three versus two drugs, and more recently four versus three drugs, to see if adding a new drug will result in better outcomes, but also, in tolerability that is similar to the three drugs. So what we actually did see over the years is the fact that nowadays multiple myeloma is becoming more of a chronic disease to many patients, where we see long-term survivors more often nowadays, and it's estimated there is more than one third of patients who may have this long disease control. And we expect this to be better with the use of four drugs. Now, when we refer to four drugs, we're referring to an anti-CD38 antibody, a proteasome inhibitor, immunomodulatory drug, and a steroid. Because the early results of such regimens did result in really deep responses as measured by minimal residual disease negativity, which reflects how deep is the response the patient achieves, and that was close to 40%, which is quite promising. I think the biggest questions that we have still is for how long should we use those four drugs? Should we use them for all patients regardless of their age and frailty? And what should we kind of use to govern the length of use? Is it fixed duration? Is it patient specific or disease specific?
So, how do you make up these four drug regimens?
So the four drug regimens is not a new concept. If you for example, one of the four drug regimens that was approved by the FDA but not used in the US is the combination of DARA VNB, which is daratumumab, Velcade, melphalan orally, and prednisone. And that's a four drug regimen that we never used here in the US. So the concept of four drugs is rather a refinement than a revolution. What we actually did is try to choose the better drugs to combine together where you have less sort of adverse events. And the good thing about those four drug modalities that they work on the multiple myeloma in different ways, as you can see in the slide. The immunomodulatory drugs, modify the immune response by using some of the immune cells that the patient has to help in cancer killing, which is really, a mechanism that is unique for those immunomodulatory drugs. And we have, three available drugs. They are lenalidomide, pomalidomide, and thalidomide that can be used, in that setting. When it comes to proteasome inhibitors, they work mostly, in killing of myeloma cell by accumulation of toxic sort of proteins in the myeloma cell by affecting what we call the proteasome pathway. The anti-CD38 is more relatively new. It's an antibody that works directly on a tag on the myeloma cell, which is we call CD38, and kind of target this cell by that way. And we believe the addition of steroids on top of that will help in direct myeloma killing by modifying immune response and inflammation. So what we use by doing these four drugs together is a multi-way of killing the myeloma cells, sort of outsmarting the cancer cell itself.
So I think still our approach to myeloma is, transplant eligible or not. The majority are not transplant eligible, but transplant eligible patients are still thought to have the best results incorporating transplant within their treatment paradigm. So how has the evolution of these four drug regimens evolved in transplant eligible patients?
Yeah, I think that's a great question. If you look at the transplant eligible patients, those are three studies that are summarized in the slide, including a study that was mainly done in Europe called the Cassiopeia study, and two studies, more sort of a recent implementing lenalidomide as an immunomodulatory drug, the Perseus and the GMMG HD7. So you can see that some of those studies have longer follow-up than other studies because they started certainly at an earlier date. For example, when it comes to the Cassiopeia study, we actually have an overall survival data published recently on that study. But you can see that the use of DERA-VTD, which T stands for thalidomide, was approved since 2019, while the use of DERA-RVD was just recently approved, less than a year ago. When you look at the Cassiopeia study, this overall survival rate is quite good to say, because we're talking about 6-year overall survival rate of 87% with the use of quadruplet-based regimen compared to 78%. And we always like to see overall survival advantage by using more drugs upfront. When it comes to the Perseus and the GMG7, those studies did report on progression-free survival, but the overall survival data is immature. And this term may be a little bit vague for some of the listeners, is that the fact that overall survival nowadays in myeloma require long-term follow-up. And for example, I always tell patients the thalidomide that was introduced early, it took many years to show that it actually have an overall survival benefit. So we sometimes really rely on other surrogate sort of responses to judge our use of such therapies. And you can see that nowadays their RVD is being approved for transplant eligible patients. Isatuximab RVD is not approved as of yet, but likely will also get approved, allowing for more options of different anti-CD38 antibodies in multiple myeloma.
So, how have these compared to triplet regimens? I think at the ASCO meeting you presented data on this comparison.
Yeah, I mean, this is a summary table where you look at different regimens across those three studies and also the follow-up duration. You can see, as we say, the Cassiopeia study have the longest median follow-up with more than 80 months. But we also see how the improvement is across the board. For example, if you look at CR or complete remission or better, you can always see better results with the quadruplet therapy or 4 drugs compared to 3 drugs. When it comes to progression-free survival, that is the same. For example, in Cassiopeia study, that was 84 versus 53, and you can see the letter NR, which is not reached for most of the Perseus and GMMG HD7 studies. When it comes to the MRD negativity, which is another reflection of deep responses, you can see improvement with the use of quad, as well as the term called sustained MRD negativity. Now, the term sustained MRD negativity will become more promising to discuss with patients because there is a movement in the field to try to define cure in myeloma based on the sustainability of MRD negativity. So some of those patients may be achieving that term that we for a long period of time did not use. The other point I want to point there is the serious adverse events. And you can see that there is no much difference between the use of 4 versus 3 drugs in those various studies. And that's really important because when we add more drugs, we want to make sure that they're not resulting in more adverse events. Now, one important thing to point is the transplant yield. We always, when we say transplant eligible patients, not all those patients will ultimately end up doing a transplant. Some of them may not be able to complete that. That's because of failure to harvest enough stem cells or patient-related or even physician-related factors. But you can see that in general, when you add 4 drugs, you may have a little bit lower stem cell yield on average compared to 3 drugs, but you can still have sufficient stem cells for more than one stem cell transplant. And this is important for timing purposes. So whenever you try to consider transplantation, especially with the use of 4 drugs, those discussions of the stem cell transplant and harvesting should come early and should be done early during that process.
And so, what about this Perseus study that you highlighted in your presentation?
So I think the importance of this slide is to reflect the fact that, first of all, the progression-free survival was better with the use of quad. as well as overall survival seems to be better, though that follow-up is really not sufficient. Now, those patients are relatively younger. We need to keep that in mind. And I think for those patients who are actually transplant eligible nowadays, the use of quadruplet-based regimens should be the standard of care for all patients in the US who are transplant eligible. The reason why, first of all, that's an FDA-approved regimen, and we have this improvement in the progression-free survival, which really, could reflect into improvement in overall survival in the long term, and the fact that those did not result in increased adverse events.
And now shifting to the transplant ineligible patients, what has been the data in this area where patients are often older and frailer on the four-drug
Yeah.
regimens?
Well, so, this is a really a subset of patients that we need to be very careful about when we kind of generalize the rule there. Because transplant ineligible patients, over the years, they did have, worse outcomes compared to transplant eligible patients. But part of that is not only related to myeloma, but rather the intensity of the treatments and or the comorbidities they may be dealing with. But it was really exciting to see the IMROS data first presented and published, as well as subsequently approved with the use of isatuximab RVD in patients who are transplant non-eligible. Those patients were older, and you can see even with that you actually have improvement on progression-free survival, as well as improvement in overall survival with an estimation 5-year overall survival rate of almost 3/4 of patients compared to 2/3 in the RVD arm. Now, when you look at the other two studies, the BENEFIT study and the CEPHEUS study, first of all, the BENEFIT study did report data on MRD negativity, but no progression-free survival, as well as the overall survival rates were immature. When it comes to the CEPHEUS study, this study did include patients who were recalled transplant deferred, so not necessarily ineligible, but they choose to defer their transplantation. And you can see that also resulted in improvement in the progression-free survival with an immature overall survival data.
And once again, how do the triplets and the quads compare?
So if you look at this summary table, you can see that overall, when we use a quad in patients who are transplant non-eligible, we have improvement in the CR or better, as well as progression-free survival, as well as the MRD negativity and sustained MRD negativity. And that's quite important. For example, if you look at the sustained MRD negativity for the use of quad in EMERALD study, that's close to 50%, which is really good. The other thing that also you need to pay attention to is the serious adverse events. Now, if you look at that as a crude number, in general, serious adverse events were higher in triplet and quadruplet compared to transplant eligible patients. And that talks, that speaks volume, because those patients are usually more older and more frailer and may get more serious adverse events. But there was no difference between both of those adverse events when it comes to the triplet versus quadruplet. The other thing we also keep in mind that those patients are relatively doing well when it comes to performance status. Most of those studies either included very low level number of patients with ECOG or performance status of 2 or more. Most of them have really good performance status, as expected in clinical studies.
So I guess you further expanded in your talk on quad-based therapy for the transplant ineligible. What else can you want to share with our audience?
So I think for transplant non-eligible patients who are less than 80 years old, which is a reflection of the IMROS data that you can see summarized in the slide, it's very reasonable to use an induction with a quad-based therapy. And the reason why the use of quad compared to a triplet did result in improvement in progression-free survival. And I put there the age of those patients. Those are really patients that are a little older than the transplant eligible patients. And you can see there is a subset of those patients who are above 75 years old. And so if we decide not to do transplantation in some of those patients at that age, the use of quadruplet-based regimen is quite, appealing, because you have better progression-free survival for those patients and also improvement in the overall survival.
Is there a role for triplets still?
I think there is, and I think that slide argues that the use of triplet is still feasible and should be done in some patients. And the reason why is that this beautiful long-term results of the Maya study. Now, the Maya study is a study that used daratumumab, lenalidomide, and dexamethasone, comparing to lenalidomide and dexamethasone. So it's a triplet study. But the good thing about this study is the fact that it included patients who were relatively older, and number one, and more frail. And with that, with a long-term follow-up of this, the median overall survival was not reached in the triplet arm for patients who are older. So the biggest question is, can we achieve what we achieve in a frail patient who may be above 75 or 80-year-old with the use of only triplet? And I think the answer is yes, especially for those patients who are above 80 years old. The use of a triplet is quite reasonable in some of those patients. But you all know we will be talking in the next slide about that this is likely not one size fit all, and we always could have do in practice some sort of modification where we start with a little bit of a quadruplet and then droplet to triplet and so on, because this is sort of a journey that the patient go through rather than something that they will remain on all during their treatment course.
So yeah, so coming to the treatment framework, decision-making framework, how do you think through this?
So I think there is three steps in my mind that comes whenever we, consider the therapy for a given patient. First of all, we need to do comprehensive patient assessment, and that means looking at certain things. Age is only a number. Age, there are patients who are there in 70s, they may be doing better than patients in their 50s. So it's always a consideration to look more carefully in those older than 80 years old, because at that time, maybe they have more comorbidities. Frailty assessment is important. And this is rather than me laying an eye on a patient saying, oh, they look good, rather using more objective measure to tell how they're able to take care of themselves, daily activities, instrumental sort of daily activities, and have an actual way of telling how frail they are. And that is also important to mention to patients and discuss with them the quality of life goals, because there are patient preferences. For example, the treatment burden, how often they need to come, and how much social support they have. And that will allow us to think about the transplant eligibility assessment. Now, transplant eligible patients, I think for all comers, using a quadruplet is very reasonable because that resulted in improvement in disease control. When it comes to transplant ineligible, I think that this is where personalization of care is important. And when it comes to patients who are less than 80, the use of quadruplet-based regimen is quite reasonable, but those patients who are more frail or above 80, they may be doing well only with a triplet-based regimen. And that will allow us to kind of think about what are the benefits of using a four-drug regimen. We tell patients about the improvement in progression-free survival, MRD negativity, and probably better, deeper responses. And that there are concerns about using some of those agents. For example, the drug called Velcade or bortezomib is associated with peripheral neuropathy, and we may need to limit the amount of using it and using it less often, specifically in patients with baseline peripheral neuropathy or patients who are at risk of having falls or something like that. And the other thing is we need to think about some dynamic ways of doing it. So maybe if we do a quadruplet initially for a given patient where your disease control them better, and then you could have modified that to more of a triplet-based regimen. And I think the field is going that way. We're trying to decrease some of those medications according to responses. And I think that is important because this way we can certainly improve patient quality of life.
So what are your key takeaways for the audience?
So I think all in all, we need always to think about myeloma in a different mindset. Now, myeloma outcomes are only continuing to improve. And with all the, innovations that are being worked at in the field, we see really improvement in that. The use of more drugs is something that we can consider in myeloma. The use of four drugs is certainly something we consider in all patients who are transplant eligible and some patients who are transplant non-eligible. And I think the key is to try to use more frailty tools over the age to determine that. And we need to think more about those adjustments, because what we use to do is a high dose that the patient can tolerate may not work as well for patients who are frail or more older. And then this balance between efficacy and toxicity is more of a personal, decision and discussion that can be done with a given patient in front of you in the clinic.
So before we wrap up, just a couple of questions. So there are, two different proteasome inhibitors. There is Velcade or bortezomib, and there's Kyprolis or carfilzomib. How do you think through the choice of proteasome inhibitor in this situation?
Yeah, I mean, in general, if the patient has no problems baseline like peripheral neuropathy, both of those agents are, I think about them interchangeable for the transplant eligible patients who are actually, in a good age with no cardiac comorbidities. To the audience, carfilzomib can result in cardiac complications as well as, bortezomib can result in more peripheral neuropathy. Now, when it comes to the standard risk patients, there was a study that looked at the comparison between a triplet and a triplet, comparing both of those agents that did not show any difference. When it comes to high-risk disease, many of us do feel that carfilzomib may have a better role than bortezomib for a given high-risk disease, but the patient with high-risk disease are quite the minority of the patients, around 10 to 15% of patients, rather than the majority. So for that question, I would say most of the patients should be doing well with Velcade, though the dosing of that is once a week rather than twice a week. Unless they have a comorbidity that prevent them from doing that, I think carfilzomib is a really good replacement. When it comes to patients with high-risk disease, especially high-risk young transplant eligible, I have sometimes preferred a carfilzomib over a bortezomib, given data that in high risk disease it may work better. And in this subset of patients, we really don't have the very strong, robust data to judge.
So you used the provocative word cure on a couple of occasions on your first background slide, and then you talked about sustained MRD negativity being a potential biomarker for potential cure. Where are we in the cure for myeloma?
No, I think the term cure is being accepted more and more in the community than before because we're seeing it. I mean, there are patients who, are living now for 10, 15, 20, 25, 30, 35, that we're seeing them. Now, rather, this is not everybody. We still have a gap that we need to kind of close, but we estimate that a third of patients are being cured. But cure is a term that patients need to have a say in it, which is most patients, if you ask them what's a cure, they tell you, I don't want to be on a treatment for the rest of my life. And this is where we still lag because many of us in the community still recommend doing, for example, lenalidomide until progression. Now, people are maybe changing nowadays where we think about fixed duration treatment, but the idea is if we change the way we treat patients to a fixed duration treatment, as well as we have a way to measure how those patients do after stopping treatment, we certainly see those patients in clinic where they are living, as well as where they live without myeloma, but without being on treatment. And we did actually publish recently the long-term follow-up on some of the studies where it implemented those immunomodulatory drugs back in the day, I would say, maybe not the same induction regimens that we have now, they're more tolerable, but we did actually see those long-term survivors. And, when the field of thalidomide, for example, there are more than 25% of patients who are living 20 years plus since this was introduced. So I think this is really exciting, and we hopefully can be using this with more kind of patients in the future, and hopefully we can increase this fraction because we still say there is 2/3 of patients who are not sort of cured or have a really good disease control that will not affect their duration of life. So I think we still have work to do.
Well, I really appreciate you taking the time to educate both the audience at ASCO and our audience. And I hope that I can have you back to tell us more as the field evolves.
Thank you so much. I appreciate you doing all of this work.
Thank you.